most of you might have a less experience on cardiac surgeries, especially the CABG is one of the important topics in this cardiac surgery because the most commonly done surgery by cardiothoracic surgeons, especially cardiac surgeons, is to do CABG. And for doing CABG or for any cardiac surgery, we need a machine called as Cardiopulmonary Bypass machine. So what is this machine? This is a machine shown here. We have to first open the sternum and expose the heart, and we have to cannulate the artery at the ascending aorta. We have to cannulate the artery, and via bursting sutures in the right atrium, it is cannulated into the right atrium. So the blood coming out of the heart, right ascending aorta is cannulated, and the blood from the atrium is cannulated. So artery and vein are now cannulated fully. So now what I am going to do, connect the cannulas to the machine. See, this is a machine. So this is a venous blood from the atrium which is connected to this machine. Okay, connected to this machine. So the blood which is coming towards the atrium will not go further, will go into this machine. And whenever we are doing surgery, we will be doing suction. No, that blood will also go to this machine. And from that machine, that will go into the filter, oxygenation, heat exchange, everything will be happening in this machine fully. Everything is going to happen in this machine. All this which I illustrated here is happening in this machine. And then the arterial blood is now coming out. The blood is now oxygenated and sent to a filter. From there, we are pushing back the blood into the patient through the aorta. So therefore, the heart is now dry. The blood is going out of the atrium and entering into the aorta by an external circuit that is called as CPB machine. Will oxygenate, remove particles, maintains needed temperature in the blood, and maintains the circulation is by means of cardiopulmonary bypass machine. So then what is the problem in this procedure? See, when you know very well, by doing this cardiopulmonary bypass, all the organs in your body will receive blood supply. But what about heart? Heart is having myocardial vessels. No, what will happen to this myocardium? What will happen to these arteries? We have to prevent myocardium going for necrosis or ischemia during the surgery. So this cardiac myocardium may be damaged and hence must be protected by cardioplegic solution into the coronary artery. So potassium containing fluids are infused into the coronary vessels, and that makes the heart arrested in diastole. So and helps to maintain the myocardium for few minutes. Or intermittent cross clamping, on and off we have to open the aorta and allow the blood to flow inside. But intermittent cross clamping can cause ventricular fibrillation, but it will allow the blood to flow into the coronary artery. Or we have to go for a total circulatory arrest. So with above techniques, the cardiac ischemia is tolerated for up to 10 minutes. In places where bloodless field is needed, as in pediatric cardiac surgery, total cardiac arrest is usually done. A new update is now there is a new technique which has come in which we can do operation in a beating heart. So beating heart surgery, this is what we call it as beating heart surgery. You would have heard about it, called as beating heart surgery. We are not going to stop the heart beating. Heart will be beating, and we will use a special device called as off-pump coronary artery surgery using an Octopus device like this. So we put this Octopus device like this and we do the bypass relaxed way. So the blood will be flowing through the normal circulation, and the blood will be allowed to flow into the coronary arteries also. So this is off-pump cardiac device called as Octopus device. Just know the name, that's enough. This is a new update. Newly the cardiac surgeons are using this Octopus device. When we are doing a cardiopulmonary bypass machine, lot of complications can happen, bleeding can happen, infection can happen, air embolism, intestinal gangrene, microembolization, myocardial depression, neurological dysfunction, pancreatitis, post-cardiotomy syndrome, pulmonary injury, systemic organ dysfunction, vascular injury. Most of these complications can happen with a cardiopulmonary bypass machine. So the one important topic I want to discuss here is about the coronary artery disease and coronary artery bypass grafting. So coronary artery disease and coronary bypass grafting you should know as a MBBS students, you should be thorough with this. So there are two important vessels coming from the root of aorta. One vessel is left coronary artery. Another vessel is right coronary artery. Please understand the picture. So left coronary artery is a main vessel. Please understand that's a main vessel for the entire myocardium. It divides into left anterior descending, which descends anterior in the heart. Left anterior descending, and another one vessel is circumflex. So please don't forget that is circumflex vessel. Circumflex and left anterior descending. Right coronary artery descends down and becomes posterior descending artery. Posterior descending artery which runs on the posterior wall of the heart. So now if you have heard about triple vessel disease, what are the triple vessel disease? We call them left anterior descending, circumflex and right coronary artery. This is what we call it as triple vessel disease. Triple vessel disease. Main vessel disease. What is main vessel disease? Main vessel is left coronary artery itself is having a thrombus. We call it as main vessel disease. So please remember, left coronary artery divides into left anterior descending and marginal branch of circumflex. Right coronary artery continues as posterior descending artery, and most commonly diseased and most commonly bypassed vessel is left anterior descending artery. So arterial dominance is a word used based on posterior descending artery origin. So posterior descending artery, I told you, usually comes from right coronary artery. In 10% cases, it comes from left coronary artery also. So posterior descending artery is from right coronary artery in 90% and 10% from even left coronary artery. Okay, don't forget this. So to find out the thrombus in these three vessels, so please don't forget, this is an illustration I am making here. This is left coronary artery from the root of aorta. This is circumflex. This is circumflex. This is left anterior descending, and this is right coronary artery and posterior descending artery. So this is the vessels we are going to see, and if there is a thrombus, we can easily identify on this investigation called as angiogram. So coronary angiogram is the investigation of choice, and during the angiogram itself nowadays, when there is a narrowing, people are started doing a stent into this vessel called as percutaneous transluminal coronary angioplasty. PTCA is a stenting. Percutaneous coronary angioplasty has become very famous now. Now the cardiologist can put stent into three vessels. They can put into main vessel, they can put into right coronary artery, they can put into circumflex. So that is called as a triple vessel itself. Nowadays they are putting stent. But what is the indication from Bailey and Love for CABG? More than 50% stenosis of left main vessel. So that is left coronary artery. More than 50% stenosis. More than 70% stenosis of proximal left anterior interventricular artery. So proximal left anterior descending artery is nothing but left anterior descending artery, more than 7. All three main vessels called as triple vessel disease, poor ventricular function. So these are the places where we have to go for CABG, and unstable angina patients are nowadays treated by angioplasty is done instead of CABG. Unstable angina is, and all you will be reading in medicine, just go through them. So chronic stable angina is now treated by percutaneous transluminal angioplasty is enough. Acute coronary angina, unstable angina becomes asymptomatic within 48 hours of medical anti-anginal drugs. If patient develops recurrent angina and ECG changes, we can go for PTCA. So for chronic stable or chronic unstable or acute coronary syndrome, all these cases nowadays, only percutaneous transluminal coronary angioplasty is done. So if surgery is to be done, elective CABG is done after 6 weeks. Okay, in these cases, after thrombolysis, we have to do surgery after 6 weeks. So when we are doing surgery for a myocardial infarction, so what is myocardial infarction? The coronary artery got blocked and the myocardium got gangrenous or necrosis. So what all will happen in an MI? Myocytic necrosis and ventricular septal rupture. So myocytic necrosis and ventricular septal rupture usually presents after 3 to 7 days of infarction with the pulmonary edema, pansystolic murmur and hypotension. Immediately we have to operate and repair with a patch. So papillary muscle necrosis causes acute mitral regurgitation, a pansystolic murmur and a pulmonary edema may be there, and mitral valve replacement is necessary, and a ventricular aneurysm can happen in a case of partial necrosis of ventricular valve In a partial necrosis of ventricular wall like this, there can be an aneurysm which is happening. So repair should be undertaken using cardiopulmonary bypass machine, and we have to do CABG in all these cases. So myocyte necrosis, papillary necrosis, ventricular aneurysm, all these are various complications of myocardial infarction. So the one important thing done by the cardiothoracic and vascular surgeons is doing a graft procedure. The first thing they will do is, once the surgery started, one surgeon will be taking graft from the vein. They take the long saphenous vein. The full length of long saphenous vein is taken as a graft, and the 10-year patency of this graft material is 50 to 60%. If long saphenous vein is not available, they have to go for short saphenous or cephalic vein. And arterial graft is done during the thoracotomy. They will take the internal mammary artery as a graft. That is the most commonly used graft. Left internal mammary artery, called as LIMA. It is also called as internal thoracic artery, is a conduit of choice because the 10-year patency rate is 90%. See, for veins it is only 50% 10-year patency, but for arteries it is 90%. Therefore, always we should use LIMA, left internal mammary artery, for left main arteries. You have to use LIMA only. Internal mammary arteries may have some limitations, especially in diabetic patients, that may not be available. In such cases, we can either use radial artery. So radial artery should be taken only confirming the Allen's test. I hope you know what is Allen's test. Ulnar and radial artery should be compressed and open one by one and see for the collateral presence. That is called as Allen's test. After doing Allen's test, if the ulnar artery is supplying the full hand, you can take out radial artery. So radial artery is used as an alternate. If LIMA is not available, we can use radial artery, or we can use right internal mammary artery, also called as RIMA. So what are the arteries used? LIMA, RIMA, radial artery are used as arteries. Long saphenous vein, short saphenous vein, cephalic vein are used as venous graft. And you can see from this picture, from the left subclavian artery, we take a long graft using LIMA for left anterior descending artery. So this is a typical LIMA used for left anterior descending artery or a left coronary artery. We use LIMA. Don't forget this point. This is a very important concept from arterial graft. So there are postoperative complications like bleeding, arrhythmias, poor cardiac status output, neurological dysfunction, wound infection. Mortality also can happen in 2 to 3%. So the carry home point is LIMA is the best, 90% patency. If you use the vein, long saphenous vein is having 50% patency at 10 years. That is the second commonly used. So bleeding, arrhythmias, poor cardiac output, neurological dysfunction, all these can happen, and 95% survive at 1 year and 60% at 50 years. The patency is found to be 60% at 15 years. Therefore, nowadays CABG has become a very common procedure for multivessel disease. Okay. Another problem done for congenital heart disease are patients who are having mitral valve regurgitation, mitral valve stenosis, tricuspid stenosis, tricuspid regurgitation. You would have read in your pediatric lot of valvular disease. So those patients we can use valve replacement surgeries. This is also a common surgery done by cardiothoracic surgeons. Mechanical valve can be used in any group and it is available in any size. That is most commonly used is mechanical valves. In practice, most commonly used valve is mechanical graft, mechanical valves. Biological valves or xenografts are commonly used. Xenografts are taken from other species, usually from pigs. Or we can use allograft. Allograft are from same species or same species in the cadaver. Allograft. Okay, so don't forget xenograft or allograft are used, or we can use autograft. Autograft from the same person. See, for example, mitral valve is more important than pulmonary valve. So if you want mitral valve, you take pulmonary valve and keep it in the place of mitral valve. That is same person. That is called as autograft. So xenograft, allograft, autograft are all biological valves. So the major advantage of biological valve is it's a soft fragile valve, so turbulence is less and therefore no damage of RBC. Whereas mechanical valve, you see here, when the RBC is passing through this mechanical valves, they rupture the RBC and release the thrombotic substances. Thrombotic factors are released. Therefore, these patients will need lifelong anticoagulant. Lifelong anticoagulant is needed for them. So mechanical valves, please don't forget, turbulence is very high. And we need to give them lifelong anticoagulants. But what is the disadvantage of biological valve? A mechanical valve can be kept for even 20 years. 15 to 20 years it can remain. Life expectancy. Whereas a biological valve, it's less than 8 years. So only for 8 years it will survive. It will go for some damage and we have to remove the valve. That is the problem with biological valve. So what is the most common complication of using the valve is thrombus. Thrombosis is the most common complication of using the valves, and thrombus formation is most common in mechanical type of valves than biological valves. And thrombus formation is most common in the mitral valve, and other complications are the valves can leak, and prosthetic valve endocarditis is another nightmare for the cardiothoracic surgeons. It is commonly caused by staph epidermidis, a microbiology MCQ, don't forget this. Staph epidermidis can cause prosthetic valve endocarditis with a mortality of 20%. So the other complications of prosthetic valves are paravalvular leaks, thrombus formation, prosthetic valve endocarditis. These points you should not forget. So mortality is around 20 to 50% with the due to the prosthetic valves. So tumors in heart is very rare. So the most common cardiac tumor is a metastasis from a lung tumor. That's all. That's most commonly from lungs. Primary cardiac tumor is usually atrial myxoma. Most common primary causing metastasis is lung cancer. Most common tumor that has propensity to metastasis to lung is malignant melanoma. So malignant melanoma can spread to various areas including heart. So atrial myxoma is the most common primary cardiac tumor. It is common between 30 to 60 years with the female common predominance, and some familial reasons are also be there. Sporadic forms are solitary, located in the left atrium. This is a very commonly asked MCQ. They are common in the left atrium, arising from the interatrial septum, mostly are pedunculated. Familial forms are multiple and seen in ventricular. So sporadic forms are seen in left atrium, single. Familial forms are seen in ventricle and they are usually multiple. So most common clinical feature is a mitral stenosis or mitral regurgitation feature. Ventricular form can present with obstructive features, and typical tumor plop sound may be heard on auscultation. Low pitched sound called as a tumor plop sound can be heard during diastole. Diastolic tumor plop, this is an MCQ. Diastolic tumor plop seen in myxoma. Major problem is that myxoma can get dislocated and form an embolus. It can go and get obstructed somewhere. So echo is enough to diagnose. Surgical excision is a treatment of choice for atrial myxoma. So don't forget this basic concept of atrial myxoma. And there is a new update from New Bailey 28th edition on thoracotomies. Posterolateral thoracotomy is commonly done in an elective case. Posterolateral thoracotomy, when we are doing a thoracic surgery, we put the patient in lateral position like this and we open the ribs. So incision is usually made below the level of angle of scapula. From that level, we will open along the ribs. So, and elbows are placed at 90 degrees and the pillow placed here. Otherwise, in a lateral position, the compression of the brachial plexus and all can happen. So, should be very careful in placing the patient in this posterolateral thoracotomy. The question which is expected is, what are the muscles cut? What are the muscles cut in a posterolateral thoracotomy? So, during posterolateral thoracotomy, the first muscle cut is latissimus dorsi. So, first is latissimus dorsi is cut along with the skin. Then, if the serratus anterior is divided, it should be close to the ribs. So, serratus anterior is divided as second. So, please don't forget the second muscle involved is, it should be closely cut at the level of attachments to 6, 7, 8. Okay. And the last one is intercostal muscles. So, 3. So, in a thoracotomy, what are the muscles cut? Latissimus dorsi, serratus anterior, intercostal muscles. 3 muscles are cut in the order. First latissimus dorsi, then serratus anterior, then intercostal muscle are cut when you are doing a thoracotomy. So this posterolateral thoracotomy is done for elective cases. In an emergency cases, We cannot put the patient on left lateral because we may sometime need to open the abdomen also. In such cases, we do a left anterior thoracotomy. At the level of 5th intercostal space, just open like this is called as left anterior thoracotomy. So, opening at the level of 5th intercostal space is called as left anterior thoracotomy, is done for elective cases. And most of you might know an emergency thoracotomy done anteriorly called as clamshell thoracotomy. Clamshell thoracotomy is a thoracotomy which is done like this, which is like opening the chest. You put an incision like this and lift the chest and go inside. So, clamshell thoracotomy is like this. Incision is made along this place. This is called as clamshell thoracotomy. Don't forget, you have to go along this plane. So, clamshell thoracotomy is another type of thoracotomy. So, posterolateral thoracotomy is done as emergency, anterior thoracotomy is done as elective. Anterior thoracotomy is done in emergency. Clamshell thoracotomy is also done in emergency. Okay, these points you should not forget. Cardiothoracic surgery is not a very important chapter for NEET PG exams as such, but some points like tumors in the lungs and like CABG procedures, mechanical and prosthetic valves, these are all high yield topics for your exams. Just go through the essential facts in a nutshell. Okay, thank you.